Hello friends, I am Pradeep here. Now we will move on to the third topic of the shock and blood transfusion, that is hemorrhage and blood transfusion. So what do you mean by hemorrhage? Hemorrhage is nothing but some that bleeding is happening. The other word for hemorrhage is nothing but bleeding. There are two types of hemorrhage. One is going to be revealed hemorrhage and another one is going to be concealed hemorrhage. What do you mean by revealed hemorrhage? Revealed hemorrhage is nothing but there is an obvious hemorrhage. Like you have a cut wound and from the traumatic cut wound you are bleeding it out, that is the obvious hemorrhage, that is revealed hemorrhage. Concealed hemorrhage is occurring but we are not able to visualize properly. So for example, any hemorrhage that is occurring inside the chest or abdominal cavity will not be visible to our eye, so that will be investigated only with the help of investigations. Or the concealed hemorrhage can also present as massive hematemesis. Hematemesis is nothing but bleeding, that is the vomiting the blood, that is called hematemesis. That occurs in occult means that is not visualized, occult GI bleed. So these are examples of concealed hemorrhages. Now moving on to other classification, that is surgical hemorrhage and non-surgical hemorrhage. Surgical hemorrhage is called only when the hemorrhage can be controlled. Hemorrhage or hemostasis can be achieved by surgical control. That means the hemorrhage can be controlled, treated by surgical control. Non-surgical. So the examples for surgical hemorrhage is any arterial bleed. So any arterial bleed, if it's bleeding, if it's causing hemorrhage, if you go and ligate the artery, that hemorrhage will be controlled, right? That is called surgical hemorrhage. Non-surgical hemorrhage is there is diffuse oozing. So there is diffuse oozing generally due to coagulopathy. Coagulopathy is nothing but there is disturbance in the coagulation. So when there is disturbance in the coagulation, it will bleed. So generally the blood it will be in a free flowing nature inside the vessel. Whenever there is any injury, to limit the bleeding, it will form a hemostatic plug, that is hemostasis, that is achieved with the help of platelet aggregation. So over a period of time, all the coagulation platelet and coagulation factors are responsible for achieving coagulation. So the non-surgical hemorrhages will be controlled by correcting the coagulopathy with the help of proper transfusion of coagulation factors and blood. The other type of hemorrhage is going to be primary hemorrhage, reactionary hemorrhage and secondary hemorrhage. The primary hemorrhage is nothing but the hemorrhage that is occurring due to trauma. So the hemorrhage due to trauma, like surgical trauma or any trauma. So when you put down your knife, when you make out an incision for a thyroidectomy or a neck dissection, the bleeding occurs, that is called primary hemorrhage. Reactionary hemorrhage is nothing but delayed hemorrhage. Delayed hemorrhage that occurs within 24 hours after the incident or a surgery, or within 24 hours. So the common causes for reactionary hemorrhage is nothing but the clot dislodgement. So immediately, so when you are operating on a neck dissection surgery or a thyroid surgery, wherein you clamp the instead of ligating it, you have you have achieved hemostasis of the middle thyroid vein with the help of a bipolar artery. During that time, the anesthetist must have maintained the blood pressure around 90-60. So you think the hemostasis has been achieved. After extubation, patient BP will be rising to 130/80 or 140/90. So that bipolar, that hemostasis you have achieved, that might have dislodged, that clot might have dislodged, causing bleeding due to increasing in blood pressure. So that is one reason. The next reason is going to be slippage of ligature. You have put a superior thyroid artery ligation. So after improper technique, the ligature will slip. So that will also cause hemorrhage, that is called delayed hemorrhage or reactionary hemorrhage. And secondary hemorrhage is generally very late. It usually occurs 1 to 2 weeks after surgery, and generally it occurs as a result of infection or pressure necrosis. So when you place drain for any surgery which is very near to the blood vessel, like in mastectomy and axillary dissection, we will be placing the drain that is nearer to the axillary vein. So the drain is nothing but a foreign body that can go and injure the vein. Due to the vessel wall necrosis, the bleeding can occur. So primary hemorrhage is due to trauma. The hemorrhage that is caused due to trauma. Reactionary hemorrhage is due to technical failure by slippage of ligature or dislodgement of clot after proper resuscitation or when the blood pressure improves. Secondary hemorrhage is due to the vessel wall necrosis occurring as a result of infection and pressure necrosis. So hemorrhage occurs. So hemorrhage causes there is loss of blood volume, right? So that loss of blood volume ultimately ends into a hypovolemic shock. So hemorrhagic shock is nothing but a hypovolemic shock. So the hemorrhagic shock can be classified into four classes depending on the amount of blood loss. So because we cannot monitor hemorrhagic shock with the help of a hemoglobin. Hemoglobin is not a perfect indicator of amount of blood loss because hemoglobin reflects only the RBC component of the blood, right? So class 1 hemorrhage is when less than 15% blood loss has happened, that is around 750 ml of blood has been lost. Class 2 hemorrhage is between 15 to 30% of the blood loss, that is around 750 to 1.5 liter. Moderate is more, minimum of 30% of blood loss has happened, that is 1.5 to 2 liter. Class 4 is almost 2 liters of blood has been lost from the body. So what happens? So generally the first sign of shock is nothing but tachycardia. So even a minor loss will cause the heart rate to rise. Blood pressure usually occurs very late, as I described earlier. That means the blood pressure starts to decrease only when 30% of blood loss has happened and already the patient is going into an decompensated state. And urine output will also be low in case of severe injury. And slowly, because of the decreased perfusion to the brain in case of decompensated shock, as we described earlier, the Glasgow Coma scale is nothing but a scale to measure the consciousness of the patient. That will also come down. And base deficit, we already mentioned, because of the decreased perfusion, more of lactic acid will get accumulated, leading on to a state of metabolic acidosis. So base deficit indicates the severity of metabolic acidosis. When the blood loss is more, the severity of base deficit or severity of metabolic acidosis will also move higher. Generally, class 1 and class 2, class 1 you can manage without transfusion of blood. From class 2 you need to treat the patient with blood transfusion, right? So why do we need to treat the patient with the blood transfusion, that we will discuss. So we have to discuss about the pathophysiology of the and the consequences of a hemorrhagic shock. So whenever a hemorrhage or massive hemorrhage occurs, so what happens? Patient will go into shock, that is a hypovolemic shock. So this hemorrhage is occurring due to trauma. So both will form a acute traumatic coagulopathy. So whenever there is any trauma, there will be activation of coagulation factors and platelets to limit the trauma and there is acute inflammatory reaction that will be developed by our own body defense mechanisms that leads to an endogenous coagulopathy initial state, that is called acute traumatic coagulopathy. Till acute traumatic coagulopathy, if we treat the patient can be easily reversed. So over a period of time, what will happen? Because of that shock we already discussed, there is a lethal triad. Lethal triad of shock is nothing but acidosis, hypothermia and coagulopathy, right? So because of that shock, acidosis happened because of low tissue perfusion and lactic acid accumulation. Acidosis will prevent the coagulation proteases enzymes, leading on to coagulopathy. Next thing, hypothermia, because of the shock there is decreased blood perfusion to the heart as well as muscles, so thereby decreased ability to generate heat, that will lead to hypothermia. In the presence of hypothermia, coagulation factors won't function, that we discussed in the previous video, that will also lead to coagulopathy. And ongoing hemorrhage, what we will do, because of that loss, patient will lose more amount of coagulation factors as well as platelets that is responsible for maintaining a proper coagulation. That because of that loss, it will go into coagulopathy. Or because of the loss, what we will do, we will give blood transfusion, we will give more of packed RBCs, we will not give balanced transfusion. So in such cases it will lead to and we will give more amount of IV fluids. So what if we give when there is already blood loss has happened, if we give IV fluids, the remaining blood will get diluted. So ultimately it forms a coagulopathy. So it is a continuum of process. So we have to control. If we knock out this thing, everything will be reversed. And the aim is to not allowing the patient to enter into this lethal triad, right? So the principles of hemorrhage control. So whenever you see a hemorrhage that is exsanguinating from the extremity, you just make a compression or you apply the tourniquet proximal to that area. First thing, you just compress, then you immediately shift the patient to OT to achieve surgical control of the exsanguinating hemorrhage. When it is going to be a concealed hemorrhage, what you will do, you need to identify the cause for the hemorrhage. So that can be done with the help of clinical examination as well as imaging investigations like ultrasound or CT to find out whether there is really a blood that is responsible for hypotension or some other cause. So immediately you start the patient with the resuscitation. So resuscitation includes airway, breathing and circulation that is going to be restored. In the form of circulation, we already discussed for all shock we will be giving IV crystallite transfusion for initially for 45 minutes. Look for the response. Then based on the response you will plan for further management. So you will be limiting the resuscitation to 1 to 1.5 liter in case of clear cut hypovolemic shock, whereas in clear cut hemorrhagic shock you limit the crystalloid and colloid transfusion. Why? We have already discussed in the previous slide. Because to avoid the dilution of the intravascular volume, thereby preventing the traumatic induced coagulopathy. So that is the one thing. And finally, whenever you take the patient for surgery, you need to identify which patient will require surgery, which patient will require embolization. So whenever there is any deeper structures where the surgery will be more morbid and it won't be life saving, in such cases you can go for an angioembolization. That is the vessel, that the artery that is bleeding can be embolized with the help of an interventional radiology approach. So suppose this is the artery that has been injured and it is spurting like this. What you do is you gain intravascular access percutaneously, and finally you go here with the help of that microcatheter and you deploy a embolic agent, right? This embolic agent is usually will be a gel foam. So when you apply it, the bleeding won't happen. So this is the concept of embolization. And there are two new concepts called damage control surgery and damage control resuscitation. We will discuss about these now. Damage control resuscitation is specifically for traumatic or to prevent traumatic induced coagulopathy. So you should not allow the patient to enter into acidosis, hypothermia and coagulopathy vicious circle. Or when the patient is already in that vicious circle, whatever you do, if that vicious circle is not broken down, the patient will die. So our aim is to bring the patient to physiological normalcy. So what do? You first control the hemorrhage, right? Control the hemorrhage with direct pressure. So what you do, you allow permissive hypotension. Permissive hypotension means you will not allow the blood pressure to rise by massive transfusion. You limit the crystalloid and colloids transfusion. Instead you transfuse with, you replace the best IV fluid replacement of choice. Best fluid of choice for any hemorrhage is blood. You should not tell crystalloid or colloid. Limit crystalloid infusion, then damage control surgery. That is called damage control resuscitation. So you apply direct pressure, give minimal amount of IV fluids, not allow the BP to rise, because if the BP rise, the bleeding will increase. Immediately shift the patient to theatre. Since the patient will be in a lethal triad of acidosis, hypothermia and coagulopathy, you limit the surgery, you ligate the bleeding alone, you shift the patient to ICU, you resuscitate the patient now, you revert the acidosis, hypothermia, and coagulopathy. Then you take up the patient for resurgery, that is called damage control surgery. So damage control surgery is nothing but you follow the principles of damage control resuscitation till hemorrhage control has been achieved. You have to do minimum surgery and you allow the patient to regain into physiological normalcy in the ICU. Then you take the patient again for surgery and do the definitive surgery. This is called damage control surgery. Now moving on to blood transfusion principles. So as you see from this timeline, even before the discovery of ABO blood groups and RH subtyping, first successful transfusion has happened in the year 1818. Okay, and from till 1970, only whole blood transfusion was given for any military trauma or a war blood transfusion. So after that, in the current era, we are giving only component blood transfusion like packed RBCs, platelets, and fresh frozen plasma, etc. So a bit about blood donation. So any person can be a blood donor. So for the donor will be screened for this transmissible infections like hepatitis B, HIV, and syphilis. So a person can bleed like or can donate maximum of 450 ml per session, and it should happen within a period of the interval between ranges from 4 to 6 months. So ideally a maximum of 3 times a year a donor can donate the blood. So we're moving on to the blood products. So whole blood, we know whole blood it includes packed RBCs and platelets as well as WBCs. So the only drawback is if we do the compound separation, each one can be made available for many patients, like, and also the plasma. So the shelf life, that means the storage capacity, the shelf life of whole blood is around 42 days, and it should be stored in -2 degrees Celsius to -6 degrees Celsius. So currently we are not at all using whole blood because more the amount of storage, more the oxygen dissociation curve of the hemoglobin oxygen dissociation curve will be altered. So the metabolic activity of the whole blood is very less. So generally the blood transfusion is given in case of anemia where the oxygen carrying capacity is very low. So the metabolic activity is low in case of stored blood. So if at all whole blood has to be transfused, it should be fresh, that it should be collected within 5 days so that it can be transfused, so that the metabolic activity will not be lost. Then moving on to the packed RBCs. Packed RBCs is nothing but you are having only RBCs in that blood packet. The volume of the blood packet is around 330 ml and the hematocrit is 50% to 70%. It has similar shelf life as whole blood like 42 days and -2 degrees Celsius to -6 degrees Celsius. So generally packed RBCs are used in any anemia or any traumatic hemorrhages. In all cases we will be using packed RBCs. Then moving on to platelets. Platelets is another blood component. The only thing for indication for platelet is thrombocytopenia, where there is very less platelet, that is thrombocytopenia. Right, so this platelet has to be kept in a special agitator, so it cannot be stayed still. There will be constant movement of the platelet machine. Okay, the special agitator, and it's stored in the temperature of 20 to 24 degrees Celsius, and it has a very short shelf life. That means the platelet, after component separated from the donor blood, it can be stored for only 5 days. Within 5 days it should be transfused, or else it should be thrown away. And moving on to fresh frozen plasma. Fresh frozen plasma is rich in coagulation factors, right? It rich in coagulation factors, and factor 5, that is labile factor, is only seen with fresh frozen plasma, not in any other blood products. Okay, so it should be stored in -40 degrees Celsius to -50 degrees Celsius. FFP is stored in -40 degree to -50 degrees Celsius. It can be stored up to 2 years. Right, so the FFP can be used in patients with coagulopathy. That means whenever there is need for coagulation factors, you can use FFP. There is another important blood component which is rarely available, that is prothrombin complex concentrates. It contains factors 2, 7, 9, 10. So there are 13 coagulation factors. So upon which 2, 7, 9, 10 is produced in the liver with the help of vitamin K, right? In case of liver failure, the vitamin K will be very minimum, so the patient will undergo into a state of coagulopathy. And also in patients where warfarin is given, warfarin is nothing but a blood thinning agent that will prevent the formation of vitamin K dependent coagulation factors 2, 7, 9, 10. Supposing the patient is on warfarin for so long, you have to immediately take up the patient for surgery. For immediate availability of these coagulation factors, you give prothrombin complex concentrate and take up the patient for surgery. And there are certain group of patients called that Jehovah's Witness. So what they do is they don't take up other person's blood, or they don't, according to the religious belief, they don't have to take blood from anyone else. So whenever such patients were met with surgery, when they are met with the hemorrhage, they won't accept, because it's against their religious belief. So in case of emergency situation, there is no other possibility other than transfusion or convincing the patient. In case of elective situations, they themselves can donate the blood beforehand so that it can be used during surgery. So how do they donate? That kind of donation is called autologous blood donation or blood transfusion. So maximum of 5 donations can be done by the patient within a period of 40 days to 3 days before surgery. And for each donation, it should be, the minimal interval should be 3 to 4 days. And the patient should have a hemoglobin more than 11 with a hematocrit of more than 34. Only then they were eligible for autologous blood transfusion or blood storage, right? So this is about the component of products. So where are we using the blood transfusion? Already know it's explanatory. Acute blood loss, anemia is nothing but hemoglobin less than 8, symptomatic chronic anemia. So in post-operatively, when the hemoglobin is less than 6, definite indication for blood transfusion, and in certain books it also tells less than 8 gram as an indication for blood transfusion. So before blood transfusion, you should know about cross-matching. Cross-matching is nothing but an immunological compatibility test that is done between the donor and the recipient serum. So here we will check the ABO and RH subtype compatibility between the both. So you shall give A positive blood only to A positive. You cannot give A positive blood to the B positive group. Why? Because in A positive group there will be anti-B antibodies. If you give that anti-B antibody enriched A positive blood to the B positive, B antigens that is present in the B positive will undergo immunological reaction. Immediate hemolytic reaction will happen and the patient will die. So that's why it is very essential for that thing. Cross matching is done. It's usually verified by 2 healthcare personnel. It usually takes 45 minutes, and in all case of emergency, if you need a blood immediately by hand within 10 minutes, you can always go out with the O negative blood group, because O group have both anti-A and anti-B antibodies, and it does not have any antigens. So it is a universal donor, whereas AB negative is an universal recipient. You can get any blood. Okay, and you always remember this balanced transfusion regime, which we'll discuss in the future. Then moving on to the complications of blood transfusion. Generally, the complications of blood transfusion, they stand around 10%, but serious complications is less than 0.5 percentage. Okay, so the following are the complications. Number one, the most common will be the febrile reaction. That's why whenever you start any blood transfusion, patient will have fever, chills, and rigor. So we always give Avil and Dexa as a pre-medication before transfusion. So this febrile non-hemolytic reaction is commonly seen in WBC rich bloods. So like whole blood, not in packed RBC, whereas in whole blood. So and also when there are preformed cytokines that are present already in the blood, in the donor blood, that is eliciting the inflammatory or a immunological reaction leading on to an immediate febrile reaction. So what you have to do is you have to stop the blood, you can plan for a leukocyte depleted RBCs. Nowadays packed RBCs will always be leukocyte depleted bloods. The next thing is allergic reaction. Allergic reaction, patient can present with urticaria because of histamine release. Urticaria, itching, edema, etc. You just give antihistaminic. That's why to control the both things we are giving pre-medication of antihistaminic, that is Avil, that is Phenergan, and steroids. Okay, so to prevent these two reaction, because steroid is an immunosuppressant, so these prevents the allergic as well as the immunological reaction. With regard to the respiratory complications, there are two types of respiratory complication. One is transfusion associated circulatory overload. So in a patient, in an elderly patient, you cannot give blood transfusion within 1 hour. It will cause overload to the circulation. Patient will have breathlessness, edema, cardiac failure, etc. So you avoid overloading rapid transfusion, and in case of overload, you give diuretic agents. The next most important thing is transfusion associated acute lung injury. Transfusion related acute lung injury, that is called TRALI. So it is an classical immunological reaction that occurs when you are giving whole blood transfusion or platelet transfusion. In both conditions, TRALI is more common. And also when you are using the blood from females, female donors have a more prone to cause a transfusion related acute lung injury. Okay, so whenever transfusion related acute lung injury is suspected, it usually occurs 1 to 2 hours within 1 to 2 hours of transfusion. Patient will develop breathlessness, desaturation, etc. Desaturation, and it gives an ARDS picture, that is acute respiratory distress syndrome picture in chest exhale, bilateral lung infiltrates. So the immediate treatment will be give antihistaminic, steroid, stop the blood transfusion, and plan the transfusion later. The hemolytic reaction is the deadly type of reaction. It usually occurs due to ABO incompatibility, ABO and RH incompatibility. So what happens when incompatible blood has been transfused to the patient? Immediate there will be intravascular hemolysis as a result of immunological reaction between the antigens and antibodies that are present in the donor and the recipient blood. It will lead on to coagulability or coagulation or bleeding, whatever it is. It causes finally death. And transmission of infection, that's why we are screening the blood for hepatitis B, HIV, hepatitis C, etc. And what is massive transfusion? Massive transfusion, whatever the blood volume you are, that is more than 10 units you are transfusing in 24 hours, that is called massive transfusion. When you give massive amount of transfusion, all blood products will be are called cold blood products, so they will cause hypothermia. What will cause hypothermia? Will cause coagulopathy, right? Because that is a vicious cycle, because the coagulation factors cannot function well, and because of that stored blood you can get this electrolyte abnormalities like hypokalemia or hyperkalemia and hypocalcemia, right? So whenever there is massive transfusion given, you always have to give in balanced form. That means RBC should be given 1 RBC for 1 platelet for FFP. Only then the coagulation factors will be maintained. So to prevent the traumatic induced coagulopathy, we always have to give in balanced transfusion. Then finally, the word about blood substitutes. So whenever the blood is not available in the recent era, there are a lot of blood substitutes that are available. One is hemoglobin based and fluorocarbon based. These are artificial bloods. Okay, so the ideal substitute should deliver oxygen, should be compatible, less side effects, and it can be stored for a longer duration, and it will persist in the circulation, and it should be effective. You just remember hemoglobin and fluorocarbon based. Let's move on to the question. So in what type of hemorrhagic shock there is 15 to 30% of the blood loss. So 15 to 30% is around 750 ml to 1.5 liter, that is seen in class 2 hemorrhagic shock. What is the most common metabolic abnormality seen in hemorrhagic shock? Any shock, acidosis, that is metabolic acidosis. The concept of damage control resuscitation is best explained by limit the damage and maximum resuscitation. That is not, because damage has already happened in the form of hemorrhage. Control the damage, since it has happened, we do not have any liberty at controlling it. Ideal thing is you maintain permissive hypotension till the hemorrhage is controlled, and during that period you give balanced transfusion in the form of PRBC, platelet, FFP, and limit the crystalloid and colloid transfusion and do damage control surgery. So this is the answer. Patient underwent thyroidectomy and developed a hematoma in the postoperative day 1. Hematoma is nothing but collection of blood. So in day 1, within 24 hours it is happening. It is usually a reactionary hemorrhage or a delayed hemorrhage. The common cause of reactionary hemorrhage being any slippage of ligature or when the clot has been dislodged after resuscitation. What is the reason for acute hemolytic transfusion reaction? Already hemolytic is usually ABO incompatibility. Which of the following component has the shortest shelf life for storage? Shortest shelf life is platelets, which is only 5 days. Packed RBC whole bloods can be stored for 42 days. FFP can be stored up to 2 years. It needs specific temperature. It's stored in room temperature 20 to 24 degrees Celsius. It's stored in -40 to -50 degrees Celsius. And packed RBCs are stored in -2 to -6 degrees Celsius. What is done to prevent the febrile transfusion reaction? So using the leukocyte depleted blood products, you can avoid a febrile transfusion reaction. So with this we have completed the entire shock and hemorrhage along with blood transfusion. We will discuss about burns, skin graft in the forthcoming videos. Thank you.